Okay, well, welcome everybody. Thanks so much for coming out. We're always afraid to have an in-person event in December, but we got blessed today, so it was good luck. So thanks again. This is the Learning Health System Collaboratory. My name is Ed Hurwitz. I am one of the leaders of the Learning Health System Collaboratory. I also have a role here at the University of Michigan, which is called the Learning Health System Clinical Champion, which means my role is to promote learning health system methodologies, philosophy, culture within the clinical enterprise. Today's session is being recorded and will be available on our collaboratory website, which is available through the QR code you see up there. So this is one of the events of our series, our 2024-2025 series. And our title today is Michigan Medicine as a Learning Health System, Challenges and Opportunities. So again, thanks for joining us today. We're being recorded, and the slides and recordings will be available on the Learning Health System Collaboratory website archive. And for those of you joining on Zoom, we kindly request that you keep your mics muted. We'll have time for audience Q&A, so please enter your questions in the chat, and we'll try and keep up with them. So our learning objectives today is to identify the attributes of a learning health system and apply this understanding to incorporating healthcare data into research, improving care, and developing an infrastructure to support a learning health system. Understand the practical barriers involved in developing a learning health system in a large medical center like ours. It's just my pleasure to introduce our panel today. We have Dr. Andrew Rosenberg. Dr. Rosenberg is the inaugural Chief Information Officer for Michigan Medicine and guides the strategic planning and operations of information technology and services across the University of Michigan Health and the University of Michigan Medical School. Previously, he was the first Chief Medical Information Officer and the Executive Director of Information and Data Management for U of M Health beginning in 2010. And then we have Nicole Templeton, who is the Patient Safety Officer, who has 25 years plus of nursing, healthcare quality, and safety experience with skills in culture change, continuous quality improvement, change management, and effective strategic execution. Her passion is in safe care for patients and ensuring systems and processes deliver safe, effective care for every patient every time. And then we have Dr. Brooke Watts, who is Chief Quality Officer and Professor of Internal Medicine at Michigan Medicine. Prior to coming to the University of Michigan, Dr. Watts was a faculty member at Case Western Reserve University and an executive leader at the Metro Health System in Cleveland, Ohio. At Metro Health, she was the Senior Vice President for Quality and the Chief Medical Officer for Community and Public Health. Oh, okay, well, that will take us then. Yeah, doesn't matter. That will take us then right into starting our panel. So I asked the panel a few questions to get them started with thinking. And here's the first question I put to the panel. Everyone seems to be talking about learning health systems these days, but it's not clear that when they use the term, they're talking about the same thing. In that spirit, what's your personal vision of a learning health system, and who, not names, but what roles or job titles will play the key roles in moving it forward? So Andrew, why don't we start with you?
Well, thanks. It's really great to be here, and I can see a number of people that I know, and it's nice. We're actually looking forward to the question and answers as well. I'm going to very purposely take a slightly different approach to answering these questions that you might normally not hear. I'm going to very purposely, very explicitly put on the CIO administrative hat. Not so much the informatician or the physician hat, to try to give that perspective around these questions. Because I think fundamentally and ultimately, decisions and priorities are financial, and organizational decisions right now are challenging given just how much our organization does. So let me start by suggesting a thought experiment. As you all came here today, you saw a lot of what the University of Michigan is. My sense is you have a sense of what the university is and what Michigan Medicine is within that as a premier academic medical center of a premier university. And there are specific elements that we can turn to in terms of selectivity for applicants, number of grants, high impact articles, and publications, revenue, whatever metrics, referrals, wait times, both reflecting potentially an opportunity for efficiency, but also reflecting an enormous amount of desire to get care here. There are many ways for us to define ourselves as a premier academic medical center or university that are visible, tangible, and that we see every day. Now, attach that to the question that Ed just asked us. What defines us as a learning health system? Would you immediately wake up, and if you agree with my first premise of that we're all members of a premier academic medical center, and we selected to work at that, I think for a lot of similar reasons, do you feel the same way that we are a learning health system in the same way? Can you define what those attributes are in terms of, for example, Marshall Runge's leadership team? Do we explicitly talk about elements of what defines us as a learning health system, as we do when we talk about our margin, as our growth, our faculty and staff burden and approval, our patient flow? Do we talk about the elements of a learning health system at those meetings? And I think the answer is no, we don't. But I do think there are elements of it that are deeply embedded in my first point about being a premier academic medical center at a university. I think we all respect the concepts. And in my mind right now, I'm thinking of Chuck Friedman's virtuous circle. When I was people have asked me, how did I become a CIO? And I won't talk forever, but this I think is an example. I said, well, on one hand, it seems entirely unexpected that a tenured anesthesiology intensivist would become a CIO, but it wasn't. When I started the job as a faculty, and I was the fellowship director, and having come here as a Robert Wood Johnson scholar where we had data that I could immediately use for research, what I wanted were small electronic systems, small EMRs, to develop the clinical data, not only for clinical care, but the data for fellows to attract them to use for research that they could quickly publish to become very good, effective faculty. And that was an example right there of a learning health system. And that was all operating in 2004. And I think many of us have that value. We see where the clinical, the academic, the education, the research work, even the organizational and operational work are all linked together for specific goals of better patient care, better research, more innovation. So the elements of the learning health system, I think, are almost so intrinsic that we forget to even bring it up because it's deeply part of our values. So what I'll end with is this. I believe we have demonstrable, measurable, repeatable elements of a learning health system in our organization and in our individual behaviors and values that are fundamental. I think that part of our challenge is to make them more explicit and to make them more within our priorities and our funding so that we actually are advancing and accelerating, and we'll come up with examples in this, accelerating these in a more explicit way.
Thanks. Nicole?
Thank you. So hi, everyone. I'm Nicole. I'm a nurse by training. With a background, I was an active duty nurse in the Army, and how you get people to change their behavior in the military is very different than how you get people to change behaviors within civilian life. So I have spent the better part of my civilian career as really a change agent of influencing. And when I really think about LHS broadly, I'm a little more simplistic. I think of it as maybe like curiosity to consistency, right? And somewhere in there, we know we need to change, and we have the data and the knowledge that we need to. I see the work I've done in safety and quality for the past 20 years as that space between we know we need to change and we get people to do it consistently. And so really those types, that culture, the structure and processes for how we get that work done from paper maybe to actual performance is difficult. And we can talk about examples, but one of the ones I have that's just very tried and true to my career is hand hygiene. That's probably one of the things that has been researched that we know we should do, right? There's sort of no argument. Hand hygiene is an effective way to provide safe care. And I have done hand hygiene work in 2 separate organizations, one a large community hospital and here at an academic medical center. And how we translated that knowledge to change into consistency is very different, even just within those 2 settings. And so we can talk a little bit more about that, but that's just broadly what I think of when I think of learning health systems. And then once you change and you have consistency, you have to go back and do the loop again, right? So it isn't just that it stops there.
Thanks, Brooke.
Hello, how are you? This is not, we're gonna make sure this is really fun. And when you leave, you will feel energized and momentum for change. That's what we're gonna do today. Because these, Andrew and Nicole, maybe you can't tell so far, but they're really smart and they're really fun too. And they know a lot. So they're gonna make sure we all feel that way, right? Yes, okay. Okay, so what is a learning health system is the question. Okay, so a learning health system has space for change, right? And knows how to help people change. And I use the words change management because I don't have a better one. That was a term that I probably didn't learn until 15 years in my career because I used to think that data was change. Data is not change, right? Correct, right? Data is not change. Change is change. Do you think the problems with change are unique to healthcare? No. So somebody really smart said something along the lines of nobody believes in any change until they see it with their own eyes. So that's a little paraphrase, but does anybody know where it came from? It's from Machiavelli's The Prince. It was 500 years ago. Nobody believed in change till they saw it with their own eyes then either. No wonder it's so hard, right? People are people and change is hard. If it was easy, somebody would have done it already. So the way I think of a learning health system now, and I think one of the big challenges we've had, and you know, I chose to come back here, right? I trained 20 years ago. I was an intern and resident. Kelly Saran was a floor nurse with me when I was an intern in 2000 on the 7C cardiology floor. I went away for 18 years and I came back a couple years ago, and because this was where the smartest people I'd ever known were. And I wanted to be around those smart people. And I think one thing that happens when we're as smart as we are, that it's really easy to ask questions over there because we're good with the data, but the data for research is different than the data we need for change. So for me, the learning health system is taking all these amazing smart minds and marrying it with the people who know how to do change management so that we are the experts in things. And I'll give you, you know, everybody here probably has heard my story about CAUTI, right? We're the international experts on catheter-associated urinary tract infections. And yet we had our rate of catheter-associated urinary tract infections was the bottom 10% of all academic medical centers. How is that possible? Well, it means that we know this over here, but we didn't know how to make it stick over here. And we have a lot of smart people. So this to me is putting the 2 together.
Well, Brooke, that goes right into the next question. Andy, you mentioned, you know, that we have a lot of resources here. Michigan Medicine's awash with resources, including the 3 units that you folks run. How do we connect the dots? How do we bring people together? How do we bring those hands together? Brooke, we'll start with you since you just.
Yeah. You know, I had the privilege, my last job, and what we mentioned briefly, I was worked at a safety net hospital in Cleveland. It was a 200-year-old footprint, more than 50% Medicaid patients in our city, Cleveland. The hardcore stuff, it was probably honestly the best job I've ever had. It was the hardest job I've ever had. And we had no money. If you know what it means to have more than 50% of your population be Medicaid, it means you have no money. Like literally, you have no money to take care of patients. Every single dollar counts and everybody does double and triple duty. That's the way you do work. So I would say gently, it's probably hard for me to come back to that perspective and see the amazing amount of resources we have because I don't think we perceive it. And I mean, that's hard, right? And that's hard for me. It's hard for the quality department to have those conversations. But I think we've had maybe privilege and too much in thinking about our resources, truthfully. And we have this opportunity to think about how we use them in support of our mission, vision, and values. So for me, we're missing something. It's easy. It's been easy sometimes to have siloed work. I think that happens more when you have resources, right? But whose problem is that? It's all of our problem. Is somebody stopping us from working together? No, we're stopping ourselves, right? We can do this. We can break down these silos. We can work together. We can solve problems together. Jeff Barnes is sitting right there. Jeff solved a problem for ambulatory care and the way patients were being scheduled for pre-op. We can solve problems together. And by the way, we brought a bunch of our problems today. We thought if we had time, we'd just lay them out there for you and let you try to solve them for us. We have problems that we can solve together, but this idea of siloed resources is our shared problem. And I think we are the shared solution. So hopefully by having conversations like today, we'll get to a different place.
Great, Nicole?
So I was talking to Andrew earlier and said, I think patient safety is sort of the notorious, we learned about this in the end of the 90s, right, with the IOM report. And I'm the patient safety officer, and we still have preventable harm happening every day in hospitals across the US. If you look at statistics, we're the third leading cause of death in the United States. That's harm from healthcare, preventable harm. So we aren't learning nationally either, internationally, I'm sure, but truly the way my work gets done, just so you know from this, is a whole bunch of smart people do research and there's really good information that comes out, and then kind of nothing changes, and then they decide to make it a standard for accreditation or a standard from CMS for payments. And so then everybody says, no, we have to start doing this because then the public is going to see how we're performing. So we all go, oh, shoot, let's put this in place so that we don't look bad publicly, right? There's a reputation piece to this. I think learning in patient safety is hard because it's not a visible problem. And if you've worked in patient safety and you know about Checklist Manifesto and airlines and learning from high reliability industries, their catastrophes are visible, right? A plane crashing is very visible. Today in healthcare in the US, more people will die from preventable harm than if a plane crashed. It's not visible. We tend to say they're sick, right? It's kind of hidden in there. And so some of this learning from each other is transparent, open communication and being honest about what our problems are. I do think the solutions are out there. I think that it's lost somewhere, what Brooke said. You had listed it on your list of, well, you have your units and then we have these other units. How can you all start working together? And I'll be honest, I had to Google what the other units were because I hadn't heard of them. And I've just worked here since 2014 fair, but I went to nursing school here and the School of Public Health, and I didn't know and hear about these. So some of it is that relationship building, that networking and learning from each other. And I mean, just the three of us in person today have already solved one of our biggest problems.
Andrew's in the process of solving one of our problems.
Yeah, it's just, it's being together and talking too.
Well, I'm able to solve it because I ran into Chuck Mayo and talked to Mike Burns and see Gretchen and see Joan. And my answer is the following. One, we have the tyranny of opportunities here. We are a extremely large, complex, really well-resourced, large university where most of us have had the experience, hopefully, of knowing a number of people who could be and are working on what we're talking about right here. I'm looking around the room. You know, Jeff, I'm thinking about algorithms you're using that will be combined with scheduling, and it will combine into what Joan and Brian Athey are doing for the medical school with AI. And then I look at the department leadership for the Department of Learning Health Sciences. What other university AMC has an entire department? So we know we have this wealth of resources. So I think there are two things for us to focus on. The first, ideally, we agree to at least a reasonable framework that we can keep coming back to. Like I said, in my mind right now, in this room, I'm thinking about the virtuous circle framework that the department has and uses to try to help organize various efforts in some degree of a manner that learnings are iterated on, the data that demonstrates earnings can then be used by Scott in surgery quality and so many other areas, right? Frameworks. I believe we need to use frameworks and agree to them. I'm going to point out two in 1 second, but I'm thinking of the virtuous circle of a learning health system. But the second are extremely concrete examples that in and of themselves move the needle forward, but then in a macro sense are exemplary for other people. Let me give you an example of literally what Nicole was just talking about. And this is to my earlier point that we have all the elements of a learning health system actually up and operating, and I think we need to identify and refine them. Nicole and I are sitting next to each other at the U of M Health Leadership Meeting, and Brooke is across the U-shaped table. And we start talking about work that Brooke, by her job, and Nicole, by their job, are presenting to our U of M Health leadership around safety and specific issues that need to be worked on. And Nicole points out to me, we have this interesting system of risk reports that come out daily, but they're still handled manually. Right there. We're talking patient safety. Immediately it has organizational priority. We're talking leaders who are looking for a solution and still pointing out a problem. And yet I know Mike Burns, our associate CMIO for AI, is jonesing to be looking for ways to bring Michael Lanham and Jeff Barnes and others together to work on this. And I've known Chuck Mayo for years working on ontologies that help us combine the language that we use, the difference in line infection, central line infection, that then can be useful to problem solve something that our two leaders here are saying, we need work on this right away. And it's something that's likely to be something that we want to do more locally, as opposed to Epic is working on that like they are on about 100 things right now in AI alone. And by the way, this is not just about AI. It could even just be about pattern recognition, as Nicole has said over and over. But as importantly, it just requires a few people who know each other to say, oh, I actually think I know exactly who can work on this. So those are, and we can find 100 of those examples in this room, a very concrete, tangible example with the appropriate people who not only have the skills, the knowledge, the desire, but then also we can align it to priorities to a group that has immediate alignment to a strategy map that David Miller has set out years ago, and it's aligned. It's not something new. It's simply aligning. But then with that work, you could start to see where it could also start to, from a learning health perspective, offshoot into research, into new investigations, into publications, into learners who come in to start to get more involved, and they become, you can see how that feeds into that framework, that machine, if you will. It's not new. There's nothing new about this. But interestingly, it started with a couple key leaders saying, I got a problem here that would in some ways initially be shocking. What do you mean? Our chief patient safety officer and chief quality officer are still struggling to make manual work automated in one of our most important areas of risk and patient safety. You would have thought, well, we solved that 5 years ago. That's an example of a concrete example that's part of a framework that we collectively just find and use to drive this forward.
Tell them about the saw blades.
You want the
Yeah,
saw blades
so
or the drakes? I have
Whichever
many.
one. So we're gonna get really concrete, to explain what we're talking about, so I think it'll hit home, whichever one.
Okay, so what Andrew's talking about, so the foundation of patient safety relies on people speaking up, right? Voluntarily reporting when they have an issue that almost happened or that does happen, whether it reaches the patient or not. That's how we learn. That's how we learn in safety, is we hear about the people doing the work and how it's going. And so he's talking about, we have a reporting system that people enter in these concerns, and in any given day, we have about 120 reports entered that we screen. Humans screen, yeah, Ann Arbor, not West or Sparrow, us here, in ambulatory and inpatient settings. And so we're screening that. And so imagine that's a human different humans every day looking at it. Well, we have a very specific equipment that we use in orthopedic surgery for cutting the bone, a certain kind of saw blade. Well, the saw blade has a part that goes into the handpiece. These two little metal pieces were breaking. They were breaking off, and all the orthopedic surgeons knew it. They were all trying to talk about it loosely, but they just sort of said, well, the institution, I've said something, nothing's changed, so I'm going to keep going. Well, it took us in patient safety, the signal finally of a piece of metal that was retained in somebody's knee that we found about a week later and had to go in and take it out. So we missed that initial signal. And I know sort of signal noise is sort of a, I don't know, blasé thing to say, but we missed the signal. We didn't hear it or see it of these blades breaking, to the point where then the clinicians felt unsupported. They felt like, we were not responding to their safety concerns. And we just simply didn't see it until it got bad enough. So is that
Because
okay?
it's a language problem, right?
Yep.
You get this, depending on who puts the report in, and then another human's looking at it. It's dependent on us doing word searches, hoping that somebody used the same word saw blade. But you can totally see how, depending on who you are, whether you're the nurse, the surgeon, otherwise. So once this happened, we went back digging through the system and we found 6 things when we really did a manual review that should have been signal on this. Should that make you angry? It makes me angry, right? We can do better.
So let me go back to my point about frameworks. And the reason I bring it up, I'm thinking of 4 right now, but we are one of the advantages that we've talked about before, our size, our complexity, the number of great schools, the number of people, that complexity for it to work to solve problems requires, in my opinion, us to not blindly, but to maybe more than people are comfortable following some degree of framework. So we agree with that framework, and that's the framework we're going to follow to do safety, to do basic discovery versus clinical trials, whatever the framework that works for you. In this case, we're here talking about what defines a learning health system. I think this is important because if we do at least agree to a framework or reasonable framework, then we can better organize work within that framework and not step all over each other. And I bring that up to my first point about, because at the end of the day, if you really think you're going to get the resource to move any of that area forward, it has to align to other priorities and to funding and other governance mechanisms. Otherwise, we just talk a lot. And talking a lot is not bad. But at the end of the day, when you now need to operationalize it, you've got to move from talk to funding. I deal with this constantly as the CIO. The irony is we run a very big, large IT organization, but almost every dollar is already spoken for run. That's my other framework I want to bring up to this conversation. Gartner IT Research, global research firm, years and years ago came up with 2 frameworks that I find important even for this discussion. The first is what's called run, grow, and transform. And that's the idea of any organization has to define where their work is to keep the lights on. And running the organization is by far where most of our time and effort and money and work go. It just does. Now, in academic centers, we have a lot of discussion of other areas, but at the end of the day, we teach classes, we keep labs running, whether they're dry or wet labs, and we take care of patients. And that's just run. The vast majority of our technology budget is for run. Yet we're generally here to talk about areas that are not really run. Then there's grow. Grow is to grow the business. Our regional network and what we're doing with Weston, Sparrow, and future affiliations, that's grow. Transform is the interesting one, and you'll hear this. When you hear people talk about transform, what I typically hear people talk about doing something differently, but if they're doing something differently to run the business, that's run. It's not transform. Transform is when you fundamentally change what you were doing to do it differently. So we, as a massive legacy university-based AMC, actually do very little that's truly transform. How many of you have completely eliminated your clinics, your hospital beds, your wet labs, and have completely changed the way research and education? How many have seen a complete 100 flipped classroom where all education is outside of the classroom? Great. How many of the other departments have completely flipped all of their education to completely disrupt fundamental classroom-based education, right? Hospital care at home, in my mind, is an example of transform where we're saying we would normally take care of community-acquired pneumonia for you in this hospital. We are now going to do it at your home. And that's not going that well. We're not expanding it massively because it's really difficult to transform. And when you hear new companies and startups saying, hey, we're going to disrupt healthcare, we're going to make general care done on your phone because, you know, young patients don't have deep connectedness to their doctor in their hospital anymore. They'll pay $23 for a quick AI-generated general practitioner care. It doesn't really happen that quickly. So one of the things that I think from a learning health perspective has to be, where are we having conversations that are really improving our run? And where are we putting time and effort to fundamentally disrupt ourselves? Very, very rare. Ambient AI that Greta and others are doing right now is one of the, if not the top AI project in U of M Health right now. Expensive, lots of effort. David Miller calling Dana and Haberme on a weekly basis. Where are we? Where are we? Where are we? That's not transform. That's run. That's trying to make the clinic efficiency better. But I think it's important that we define these, because where we have to transform fundamentally how we work. Oh, let's argue about it, but fundamentally, instead of typing, I'm just now speaking. That's really important work. Don't misunderstand. I'm not saying it's not important, but that investment right there, in my opinion, is in the run the business, not into fundamentally transform and disrupt how we do our work. We have to be careful in frameworks then where those concrete examples are. Please disagree.
I was gonna say Greta on you. Greta, what do you think? Does everybody understand what we're talking about? So, okay, yeah, let me explain it. It's like this. I'm the doctor, Nicole's the patient. I have my phone. It has ambient AI on it. It's going to listen to me while we have our little visit. We have our visit, we chit chat, we do our whole thing. We come back, we talk about her blood pressure. We go off on a tangent about her foot. She broke her toe like I did. And then we come back to her blood pressure. And right now we have very limited tools. You either have me type in, and I type really fast. That's why I have this overuse injury. But we typing out my note at 100 words a minute, or you have a dictation that's listening to me and putting it in verbatim, where you get the stuff with the blood pressure is disorganized. Or you use an ambient AI technology that's trained on large language models that organizes the note in a way that I would write it. Okay. And so right now, many systems, our system at West has been using this for 3 or 4 years. It has saved 7 minutes a visit in primary care. And for the first time ever, the CMIO says that people stop him and say, this is the most important, best thing you've ever done for me in my whole life. And now I get to see my kids now. Swear to God, I'm not making it up. But it has to do with the way that it changes how we interact with the machine and how we get back to why we get up in the morning, which is hopefully to interact with patients. So we are running this right now, thanks to the work of Andrew creating the space to get this change in, and our CMIOs to get this in place. So I'd say it's transformative, but it's fascinating, right? Because we're doing this in real time. Talk about a learning health system. So we guess, what Mike Burns says, and we could talk about it. He's our AI guy. He says about 1 note out of every 100 will have a hallucination in it.
We have hallucination, you said.
Yeah.
So it's added something that you didn't say.
But I think the words matter. And the reason I'm bringing it back, and I started, and I'm going to
Yeah.
continue, I'm going to be very consistent. They matter because fundamentally, ultimately, where are you investing your money and time? To transform someone's life, I could give you scribes, and that transformed some people who really had trouble when we first did Epic. Just give someone in the room to do the typing for them. That was transformative or helpful to them. That was not transform in the specific use around a learning health system, in my opinion. When we're trying to find money to do completely new work, for example, in AI, go to the future, not that far off. An agentic AI will fire off and automatically change antibiotics based on the microbiology that comes back. The transformative part is not the computer algorithm, it's that we will allow a computer to act like a certified clinician. We're not there yet, but that would be transformative in order to meet other business goals. I happen to think, the reason I bring it up again is that if we're going to put $1 million into ambient AI, recognize that's money in the run part of our budget. And transform is usually higher risk. It's something we don't know if it's going to work. A lot of people talk about it, but to truly do something that's transformative for the organization, not an individual. And that's why the words are important. This is, and Greta, you know me well, this is no disrespect for what we're trying to do. I think it's incredibly important work. But when we talk from a learning health system perspective, I think the specificity of the words and where we are investing money is really critical. Because otherwise we think we're doing transformation when we're really just improving run, or we're spending money on grow, or worse, we're spending so much money on run and grow, we really are not purposely putting 2% of our revenue towards true high risk transformative efforts, many of which will fail. If you think like venture capital, 1 in 50 will hit it big. 35 to 45, they know will fail and in 5 years will be gone. That's how venture works. Private equity works different. They work to 10x something that's already working. Now, how do we translate those kinds of ideas to what we're talking about? What faculty says, look, I want to try a moonshot. And the reality is I'm likely to fail. As opposed to other people saying, I'm going to churn out good work. We're going to get good papers. We're going to get R01s. In some ways, that's not really that transformative. That's part of our academic work. I think when we talk from a LHS perspective, we need to use that precision, because then we can decide where in that virtuous circle the risk pro work in my mind is just improving our run. We can do things in a different way, but we're doing it to just improve basic blocking and tackling.
All right, I have a question based on everything you've been talking about. So you all know, but I don't know if everybody knows, I used to be a department chair. And I was here in 2012 when we adopted the MyChart EMR. And there was a curve you could draw with acceptance on one axis and age on the other. The older you were, the less acceptance you had, the more problems you had with it. We had people in my department retire on August 11th because August 12th was the day we were starting MyChart. Brooke, I have heard some of the stories similar to what you talked about with the metal in the knee. They're just cringeworthy. Why don't my faculty talk to me about it? So my question to you is that how do we bring this right down to the faculty level? How do we get them interested? How do we get them to do something different than what they've been doing? Ambient AI, okay, 1 in 100 hallucinations, more than 1 in 100 are going to just be inaccurate. How do we get the faculty to be energetic enough to actually look through and make sure that the AI knows that not just accept it as it is and inaccurate information, right down to the faculty level?
So small funny, and maybe some of you know this and some of you don't. But so we have a really remarkable compliance officer that Nicole and Andrew and I work with every day. Her name's Jean Strickland. And she's been very interested in the AI space because, as you can imagine, there's a lot of compliance issues. So we're talking the other day and I say, well, we're talking about these hallucinations problem. And Jean said, I'm not so worried about that. I'm worried about the way the notes are now, because everybody does these checklists and I know they don't do half the things they check off in those boxes. So I'm thinking this AI thing might actually be better than what we have. So it's this moment of going, oh my God, what we have is not so good, which is, your Andrew's point, but maybe that what we have might not be perfect. Perfect shouldn't be the enemy of good, but not better. I hear there's comments, but let me go back to this. How do you get people to do? The older I get, the more maybe I get in grumpy pants. I don't know. I don't think it's our job to make someone want to make be interested in quality and safety, and actually don't think we have to. I think most of us choose to work in healthcare because we think maybe, and I realize we work in all different aspects of healthcare. You don't have to be touching a patient to be working in healthcare, friends. We choose because maybe we think when we get up in the morning, we can make somebody's day someday at some point a little bit easier. Maybe, hopefully, we have a chance to relieve a little suffering at some point, at some moment every day. That's why we get up. That's why I get up. I think that's why we all come to work. We want to have that some small amount of impact where our jobs actually feel like they matter. That's healthcare, and we're privileged in healthcare because those connections are so easy to see, right? Okay, so we're just trying to make the day a little bit easier for somebody. And maybe it's the person next to you, or maybe it's that patient in the room, maybe it's your colleagues, or maybe what you're building is going to help keep patients safer in the long run. So if there's a failing or a moment where I think we can do differently, we are failing perhaps to make those connections explicit for our colleagues, for our faculty, for our staff. So why do you get up every morning? Why do you get up every morning? How do we create the space where you see that meaning? It doesn't mean everything is golden all the time, friends, right? There are crappy days and there's hard work, but you should see how that work connects to the bigger space, right? So I would say, I would put it back on all of us, because whose problem is this? It's my problem, it's your problem, it's all of our problem. How do we show this meaning, truly meaning in work? Because there's a funny thing. So we do a lot of quality work, right? And it's one of my big pains, and I hate quality measures. They're all bad. We could talk about that all day. But when you pay doctors, there's always, somebody always wants to pay doctors to do quality measures, right? And it doesn't work. And it's never worked. I've tried it for 20 years. All the papers say it doesn't work. You can't pay doctors to do quality measures. Do you know how you get doctors to engage in quality and safety? You show them what they're doing. It makes the lives of their patients better. It's purely altruistic. Geez, it's why we got up every morning, no matter who you are. So to me, the question here is, how do we, and I own that we're all leaders and we have to lead where we stand, and that might be where you are, and in whatever way, how do you help us see that meaning and work? So that was probably too much for lunchtime, but that was my answer to the question. Do we want, I think, yeah. Yep. Yeah.
Thing that broke off in the ortho surgery.
Please don't let me see this in the newspaper, right? Like, we all are keeping it in this room. Okay, go ahead.
I think it's a really great example of where concepts of a learning health system really come into play.
Mhm.
And one of the main concepts I always think about when I'm thinking about this type of work is asking the question of why. So why did it break off?
Right.
But then why did it happen in the first place? Why didn't anyone tell it?
They did tell, we just didn't see it.
Yeah.
And they're like, why didn't you see it?
It's manual.
It's 3 different people looked at 3 different reports. We didn't pick up on the trend, but in reality, an orthopedic surgeon, we have a lot of stereotypes in healthcare, right? An orthopedic surgeon probably has the stereotype of, well, I said it while I was standing there. You guys chose not to do something about it. And actually, in this case, I would say they were a lot better about going, you're right, I should have taken that up the chain of command. I should have made sure something was being done with it. We have this sort of sense in healthcare of, well, I said it. What didn't, right? You guys all do. So absolutely, we do root cause analysis on every, right, preventable harm event that reaches our patients that causes a certain harm. We ask why all the time, but yeah, going back to that very basic of the symbol. Mm-hmm. Can we talk about culture for a minute? Yeah.
Just a minute, Nicole. I think
Yeah.
we'll talk about culture.
it's amazing when you really think the science of safety, everything that's out there, human factors engineering, we have colleges and programs for this very, defined rigor around the design of our equipment, the design of our workflow. And culture gets in the way of all of it, right? In reality, being willing to speak up and be transparent, being willing to listen. So much of my work has been soft skills lately, trying to teach people relationship skills and teamwork. I work with a group right now, the Center for Interprofessional Education, right? It's a program here on campus trying to get together nursing and medicine and pharmacy, right? How we have interprofessional teamwork. I'm on this group because they said, we're teaching all these students this best practice. They're not seeing it or feeling it when they walk through your hospital doors, right? So they're learning this interprofessional teamwork, but it's not in practice in our doors. Go ahead.
Does everybody know Kelly? Kelly sees all the worst things that happen.
Mhm.
In my practice over the last 20 years, I've gone to a lot of different institutions to speak or learn from them, obtain reviews. And I think that one of the things that has really struck me and other people have commented on, the minute I've walked into another facility, people were eating lunch together, different disciplines. They were actually hanging out, respiratory therapists and physicians and, saying hello to each other and the janitor. Michigan does not have that atmosphere where as much as other places, and I'm not saying that doesn't exist. But I think when we talk about speaking up for safety, if we don't say hello to each other, how are you going to feel comfortable speaking up about anything, right? So we tell people, speak up, right? But we don't give them examples of how to speak up. And also, a duty to go up. I said something, like you said,
Right.
that feels like, well, somebody should have taken the ball and run with it. So
Yeah.
knowing, what those steps are and the framework, I think the framework is so important. Like,
Mm.
thinking about this categorically. About Mike. Talk about care. Wait, a question for Andrew now. To have truly transformative care, it doesn't cost money.
At some point, transformative care becomes the run, right? I mean, but yeah, go
Kelly, I
ahead.
would
Oh.
argue that it doesn't change anything who owns interdisciplinary team-based care with a patient at center? We all do. I mean, I hear you, but it is us. We are they. Yeah. Yeah.
Yeah, so to that point, I'm Stallberg, I'm faculty in both OBGYN and
Hi.
the Department of Learning Health Sciences. I'm the founding director of our Hills Online degree program. Some of our students are here. I run the Medical Education Scholars Program. I want to change this tenor a little bit to a much more positive view. And so what I am hoping we all come away with is that there are these frameworks, and in this case, we're talking about a learning health system where we think about knowledge to practice, practice to data, and data to more knowledge, right? And how we all work together in an HRO, and we use our HRO principles to actually say good morning, to listen to one another, to not throw stereotypes around, right? And so, yes, things cost money. And as my former chair, Timothy R.B. Johnson, used to say, you cannot change the wind, but you can trim your sails. And so I would just like to challenge us all to actually own our own piece and part of this puzzle, rather than pointing to everybody else. Right. And that we can all learn, right? This is so the foundation of IP. I used to be the faculty lead for faculty development in IP, right?
Mhm.
The 5 competencies of IP have nothing to do with healthcare. They actually have to do with us learning each other's roles and responsibilities, right? with us understanding what team and teamwork looks like, right? I won't go through all of them, but I just would challenge us all to, instead of sitting in what isn't working, is to find all of the bright stars where we are figuring out that like, hey, Jeff can make some things work, right? OBGYN pivoted 360 degrees. We spun ourselves around to continue to give obstetrical care online, and we continue to use telehealth for OB care. That's transformative. We can do this. And I just want to say, to Andrew's point, that I think the learning health system concepts and virtuous cycles and the science behind it is one of
I just want to say that the model of, people working together, eating together, learning together works very well in there's certain clinical programs. I'm familiar with the brachial plexus program, peripheral nerve program. That's exactly their model. They have a little learning lunch session. They're publishing together. So it works in small models. How do we get that to work in the larger enterprise?
Ranjit?
Tim, I know for the last 9 years, what I've come around to see, and it ties back actually to the ambient documentation and work like that, is that the extent to which people are able to invest energy in saying hello, interacting like they know they can, in washing their hands, achieving, safe care, all those things, the extent to which they're able to invest that energy depends on how not burnt out they are. We have to make sure that we're not burnt out. We have great people who can function in great ways when they're not burnt out. But if we burn them out, they function in this survival mode and they don't do any of those other things. And we don't want to be there. So that's why I see these other things we're doing where if we can achieve a measurable difference in burnout through a tool, and that I think that can translate to dozens of other benefits that go way beyond the tool.
Yeah, we talk a lot about attention, right? That's what we're all vying for, is attention right now. That's what we need. We need the attention. And the more discovery, the more siloed work we have, the more regulations we have, the more data we see. Every one of us who's responsible for the success of that needs people's attention, right? And so we have to figure out a way to do this where it looks comprehensive and holistic. I mean, the leaders on the front line have, if you know Jack Philly, he always had a cork helmet where it was like all these things stuck in somebody's helmet, because we're all coming at people from all different angles, which is what I really appreciate from that Center for Interprofessional Education work. Is well-being is at the table, patient experience, patient safety and quality, diversity, equity, and inclusion. I mean, this is like all of us comprehensively thinking about how to do this instead of these 12 research papers try to get implemented 12 different ways. And I know that was a very simplistic way to look at it. Are we doing?
We're question and answer. Just keep on.
Go ahead.
Yeah, okay.
Yay.
I'm also on the faculty of school information. But going back to this woman's comment right here, I think today about being positive, I think the most impact experience I had in this learning health system model. Now I won't go into the whole story, but I actually had a health issue, a cardiac issue, chest pains, and I went to see my doctor. This was at U of M. They gave me some stuff that didn't work. I admitted myself in the hospital. They gave me some other medication that didn't work. Then I went to one of my providers I know personally at U of M, who happens to be a Black man, who discovered that I had never seen a cardiac professional during my whole situation. And he took the initiative to get me a referral to see a cardiologist. I in turn had a stress test. I had found out I had a 95% blockage in one of my arteries. Then the hospital was like, oh, you really need to kind of get the procedure, which went fine. I went back to the physician who I told me that my case became a teaching tool for the medical school about the fact that I was 40 years old and I was a Black woman and didn't really like far on them, I guess, that I might have a cardiac issue. And that's to say that's to me a positive example. Of course, my health had to be at risk to get there, but
Yeah.
I think to the extent you take something like that, I would like to think that could be repeatable. But I think it's ironic that as a person who works in healthcare and I teach in health administration, I feel my biggest impact when I was a patient.
Yeah.
Make a change. But I would like to think you don't have to have individual patients, kind of have to be the people who kind of lend this, make this happen. So I just bring that forward to get your thoughts on kind of where that could go.
Well, we're glad you're okay, and thank you for sharing. And you have highlighted something that was a great point for the group to take away as well. So what is our number one cause of patient harm in our health system or any health system? I'll give you a clue. It had to do with the story we just heard. Diagnostic errors, diagnostic delays and diagnostic errors. Number one cause of patient harm, right? So technology, learning health systems, how can we leverage it? I don't need another model to predict who's going to get readmitted to the hospital. We don't need that. What we need is ways so that these kinds of cases, and we're not always going to get them right. We're always going to be learning. But right now we're dependent on process of saying we're going to teach this. So that's one tool. How else can we build our system so that we learn from these kinds of diagnostic errors?
You know, there have been a couple, as I was walking here, I was thinking about something, and actually several of you have already touched on some things that I think are important around Ed's question still of what is a learning health system. Jack Billy's name came up. I hope all of you know Jack. If you don't, you should. HRO came up, and I think like those concepts, one of the answers again to Ed's original question is a learning health system is a organizational recognition of a need to identify itself, but it also has some very specific elements. I've talked about not only a department, but its leaders, but the fact that you're all here, the fact that we're spending time and effort. There are a lot of health systems that would not give you the time or give us the resources to have these conversations so that you all could get to know Nabil Rad and Sean Meyer, two of our great data people, because at the core of any learning health systems, as Karen pointed out, will be not just the data, but inevitably the iterative improvement and continuous improvement of the data that becomes the information that we act on in that virtuous cycle, just as our colleague said about her own care becomes now part of our culture and this continuous cycle. There was a cycle you just saw that's now working itself through our health system yet again. I give a talk frequently around this topic. Some of you may have seen it, but in it, I have a slide that I only have the words to start with, where the person says, I am fain in any case to find records suitable for comparisons. I have the feeling that if we can find these records, improvement in life would occur. And I say, just listening to the language, and there's more to it. You know, it's not someone speaking today or a couple weeks or years ago. Anyone know, if you haven't seen the lecture, who said that? It's one of our greatest healthcare leaders of all time in the United States. Florence Nightingale. Florence Nightingale said, I can't find records fit for comparison. The reality is we're constantly going to be reiterating on the information and the data we use, not just to make it better and better, real-time data latency instead of a week, I need it today. But it's an iterative process that I would say in that framework is an example of our collective work might be, where do we need to spend time on ontologies that will work around specific use cases that we know are important. My first part, it wasn't, I hope you didn't take it as any kind of cynical side. I don't think you did, but that also are attached to ongoing strategic efforts so that they will get support and work. Not all of them. Sometimes we have to take flyers, but to really make this work, we have to do work that is attached to our tactics and our strategies and our academic work and our clinical work so that we get the support from our leaders who are trying to move the needle forward. So start with data and then how data becomes information and how we then iterate on that to make it better. Sepsis models. I wish Karen Deep Singh was here. If you don't know Karen Deep, the University of Michigan and several of our faculty and many of our nurses did the country and maybe the world a favor by showing the existing models were not good enough and we need to do better. And the second layer will never be good enough, and the third and the fourth, but that iteration is actually probably where the value is. And we do this collectively. So I just bring this back to Ed's point. What is required for us to be? Well, Jack Billy did this kind of work a long time ago around how an organization operates more efficiently, lean technologies, making problems visible. And many of us who took that training, in my case, 15 years ago, it's still part of our learning health system. It's a technique. And in the same way, as we thought about high reliability, I was the one saying, you know, as a intensivist, this is crazy. Aren't we all high reliable? I want the person cleaning the floors to say, hey, doc, I think we have a problem here. That patient might fall out of the bed. Thank you, Rick. Not who are you, but no, thank you. That's just, I thought, part of our DNA, but it is part of the culture and it goes forward. I think the LHS concepts are in the same light. By the way, they're in the same light when we talk about diversity, equity, inclusion. They become frameworks that we use individually and organizationally and collectively to advance what we are. But then, so it's not just talk. How do you take that framework and divide it out and say, here's where we need time and effort? The irony, as the CIO, is that I take it from the data perspective. And that's why if you don't know Nabil Rad, if you don't know Sean Meyer, if you don't know a few of the other people, these are people who wake up and go to sleep every day talking about our data. What can we do differently? Justin Pestru in your group, I can think of many others. Our associate CMIOs, almost to a person, are dealing in data. What data do we collect that we need to move the ball forward? Who do we know that can be involved in concrete projects to improve the data to the information part of that? There are many other parts of the framework, don't misunderstand. But I'll end with this. I became the CIO not because I'm a tech, not because I have computer science and I was a computer engineer by background, biology and history. But in understanding how critical digital is today, there's no industry that I know of, or very few, and certainly not healthcare, where now more and more every single thing we're doing now is become digital or needs to be digital. And therefore the technology underlying it, and more importantly, the people who understand the technology and understand the business, is part of our learning health sciences. So I would say the data, but then it's the individuals. I can't answer. Some of the faculty in 2010 said, I'm done. In all technology adoption, if you've ever read Joel Howell's work or Howard Markel or any of our own medical historians or other historians, there's a relatively bell-shaped curve of adoption. They're the early pioneers, the early adopters. Most of us are in the middle. And of course, there's some who will never change. And by the way, part of our goal then is to also make sure those people who will never change still are productive, understanding not everyone will. But as we get into new technologies, you know, as we start to do more robotic work, as we start to look at workforce changes, as we start, you know, there's so many areas of our university. We bring in College of Engineering, we bring in School of Information, we bring in the humanities, we bring in other areas because we're solving complex problems. We need diverse teams to look at them. That's part of this model that I was talking about. So I bring it up because I think it's important for us to define where we sit in that model and where we're putting time and energy, and then where we can say to each other, hey, Andrew, you're not putting enough time in this area. Thanks, Jeff, I get you. Or no, we need to still focus in this for right now. That's where we also move the needle forward.
Yes, please.
Jeff Barnes. I want to build up all of you today. You take an LHS approach, thinking about how to solve these problems in a learning model. The data to show that we have something to learn from, and the data to show that we're actually making change is really important. And I'm wondering how you would propose addressing two barriers that often come up. And the first is the issue of frequency. Something that happens rarely is really hard to identify, but it's even harder to show that you've made impact. So I think about the retained device element, right? Finding the problem is one thing, but showing that you're actually changing it is another. How do you start to address that problem in a learning health system model? The second is around something Andy you talked about earlier, which is the financing of resources. And so how do you prioritize projects that don't lead to fiscal wins? So how do you work through both of those when you're trying to use a learning health system model? I'd love to hear from that higher level perspective what you.
Yeah, thanks, Jeff. So, yeah, I do. This is good. This is good. So yes. So we have this big problem here. I told you we're going to help us solve problems. We can't measure quality and safety from an EHR. Did you know that? We can't. So we have about 20-ish, and I'm a little being a little exaggerative, but we made a bunch of electronic quality and safety measures, and they're all really bad. And most of them have been used, the ones that are publicly reported have been used for more than 20 years, and many of them have had to be retired because the margins of errors in them are so tiny. And I'm going to use the example of the catheter-associated urinary tract infection. So I told you we perform in the bottom 10% of all academic medical centers. At least we used to. We're better this year. So how many did we have in a year to be in the bottom 20% of all academic medical centers? How many visits did we have last year? Any inpatients, Ranjit or Andrew? How many inpatients did we have last year? I think probably what, 3? Does anybody know? I think it's in the hundreds of thousands, right? Then admissions, yeah, I don't know what, yeah. Yeah. So, and I don't know with OBS, it gets really confusing with the OBS patients. So that's why the number isn't fresh in my brain. How many did we have to end up in the bottom 10%? Catheter-associated urinary tract infections? Yeah, somewhere between 60 and 70 total. Okay, like nothing, right? And that puts us in the bottom. Why? Because we haven't measured anything else, because it's public, because it goes into Leapfrog and the payoff of it. So everybody took the test and they figured out how to game that measure. So where I'm going with it is we really, really, really don't know how to measure quality and safety. So this is the problem, Jeff. So one thing is we need better ways to leverage EHR information, data, whatever's there, ambient or otherwise, to measure quality and safety for patients. Talk about an open book. I swear to God, there's nothing there. This needs a new narrative, and it's going to be written based on ambient coming out soon or in this process. So, you know, how do you find what's there? Well, if you're a learning health system, I hope to God you have a relationship with, for example, your safety folks who are going, you know what? We have this horrible manual system. Everybody in the country uses this horrible manual system where we can't look for patterns in the data. So people call something different with a little different language and how they report it differently. And we can't see it in this information unless we try. So I hope that we, you know, connect the dots in a way that says we can solve these really important problems that you wouldn't see if you didn't, you know, we didn't bring the system closer together. But ultimately, we need better measures of quality and safety. I think that is an open book. The fact that CMS defunded NQF, everybody knows that they did that. There's a reason, right? We had 2,000 bad measures, none of which really got a meaningful quality and safety. So that's an open book. Second thing is about money. It's an open book test. What are the institutional priorities for 2024? What are the institutional priorities for 2025? Or I guess FY25? So, I mean, it's pretty simple. They're the base priorities. They're David Miller's. If you don't know what they are, Google it. It'll come up. And I think when we show that we align with institutional priorities, because we can't do everything, then there are opportunities and resources. That's my very simple answer.
Hey, Jeff, let me add to that. Something that Karen said, I want to come back to. You know, we do have a lot of positive examples. I think part of the answer in your question is the people in this room, and I don't want this to come across as too solipsistic almost, but I'm looking around the room and I recognize a number of faces, and this is maybe as much to the younger and the students here. We're a really, really big organization, but nothing works better than when we know each other. And you know what people are working on and where their talents are, and you just connect people. And one of the ironies, at least, or maybe what I've seen, is you start out in your career learning and learning, you establish a role, you kind of sort of prove yourself, but at some point you get to the point, realize it is no longer about me. And that's a very personal point where you get in that, but hopefully most people get there, where then it becomes more and more about others and others. And as I'm thinking about your question, Jeff, I'm thinking about the fact that in my opinion, our CMIOs, our informaticians, our nurse informaticians, our informaticians, and I don't mean just in the more strict data and use of knowledge, I mean more in that operational side, are increasingly important to translate the technology and the digital that I've talked about that's so fundamental to operations. And And I don't want to discard the fact that it's not all about technology. It really is about people and how we talk to each other. But increasingly, to Ranjit's point, the technology has absolutely demonstrably added to the burden also. And one of the reasons is that inevitably, if any of you remember Julia from School of Information. Thank you very much. You know, she would give wonderful talks about, and I also would talk about the productivity paradox, known from the 70s. If you added technology without changing the underlying work, you actually usually add burden. You don't. It's only when you either modify work or the technology modifies the work that you really see productivity. And we see examples of it constantly, right? I think for some people, the EMR adoption was fantastic. Go to any of the junior people, the students and the residents who are keyboard are just flying. They're like, this is great. Go to a 55-year-old person who is printing out their emails. This was terrible, right? No, and we had faculty. We had faculty who had their administrative assistants writing prescriptions for them. We just did. Now, those were very, very few, but there's no way that a modern EMR is going to work in that regard. So I say this because Mike, I remember the first time I met Mike, we were doing executive rounding and we were talking about the burden of the texting. And as we were talking, one of the nurses there, the beeper is just, or their phone was just going off and off and off. And Mike appropriately said, what are we going to do to change this? That was a great example. This was before, you took on your new role. My answer, Jeff, of the first part are the people who do have combined more skills. They have clinical or operational experience. They have great communication skills, and they understand technology and how it's useful or how it's not. And we need more of them. We just do. Greta's a fantastic example of this around a number of things in ambulatory care. Michael Lanham, I'm just looking around the room, and I can see many, Ranjit and others. The second part about finances, it gets back to my earlier point. In my experience, and especially as a CIO managing a fairly large budget, I think it's important that those experts that I talk about increasingly understand the finances, say, hey, we need to invest in this for these reasons, and they're attached to the goals that Brooke talked about. Because if you don't, it's just talk. And I'm not trying to be cynical and administrative to you. I live this every day. Talk all you want. It's not going to translate into real action. I'll try the best I can to attach this to work. But that's why, for example, with Chuck today, it's kind of fun but important work. I heard from two of our key leaders here of a real problem. And I think I know people like Mike Burns and Chuck Mayo who actually can help, as opposed to just wait for you're an Epic, we'll do this. Which, by the way, is more of my answer. I'm more answer say Epic will do that. So please don't waste time and energy and the money you don't have, because it's coming with their 3,000 developers. Please don't waste your time.
So last question. Yeah.
I mean, we talk a lot in patient safety about learn locally and share broadly. We can't quite get a sense of all the improvement work happening around the institution just for safety gaps, right? I mean, everybody's trying to solve problems the best that they can. I think we all perform a lot of heroics to deliver safe, best patient care too, unfortunately. But no, and we were just talking about this, some type of database where you can put in what it is you're working on to improve, and it's under a category. Is this patient safety? Is this right? And that we can actually see the work. We're all kind of in our days, right? And it's amazing to me how much people want change. For someone like me, I want consistency, right? It's our It's our business to make the systems around our staff and faculty work. I think it's our responsibility as an institution, but we can't do that unless we learn from them. And when they think that the heroics and the workarounds they do every day is just normal business, we're not going to learn. We're not going to be able to improve it for them. So I know that's not really, I have so much going on in my brain right now, you guys. This is great, right? I mean, we need to do this and we need to talk about it, but at some point, the improvement work is so vast that the people who have to deliver the care can't keep up with it either, right? And that's the work, like, so the CQIs at my old hospital, I used to run core measures and I owned all the CQIs. Skip Campbell came out for a visit to find out what we were doing because we were performing so high. At Foot Hospital in Jackson, Skip Campbell's out there and he's saying, University of Michigan, we can't get there. We're the lowest performer there is. What are you doing in your large community hospital? It's very different. You can see change very easily in large community hospitals. You all know each other. You see each other all the time. You do a little bit of everything. I was the director of performance excellence and I was working on utilization review with care management. As the patient safety officer here, I don't see the people. I'm not with them. I don't wear a lot of hats. I'm very deep into a certain expertise and it's hard to learn whenever you're like that, right? Sorry, I have so much in my head, but you guys were all like brilliant, smart, like well-intentioned. Everybody in our organization is, and we have to figure out how to harness that, so.
See, I think we have 1,000 learning communities. I think, again, the tyranny of the opportunity here is that we have departments and divisions and what we're doing here. The classic, phrase of plans are useless, but planning is critical. Joan's probably going to yell at me after I say this, but the work that Joan is helping to lead around the medical school's generative AI is an example of one of those learning communities that was brought up around a specific topic. The plan itself, the output of that, in some ways is unlikely to be the most important thing. What's probably going to be the most important is that the various different work groups coming together and then working among themselves will create the relationships to actually know what we need to do. Ironically, in IT, we have what are frequently called communities of practice. It turns out the University of Michigan has, if not the largest, one of the top 2 or 3 largest Tableau communities of practice in the country, according to Tableau, the analytic platform. And it has, a couple hundred people spread throughout the University of Michigan. Those best practices, those people talking to each other. Again, you keep hearing me talk about data, but we brought together most of the key data leads within Michigan, Michigan Medicine, but certainly U of M Health, to continue to talk to each other about data liquidity, reuse of data, the inevitable challenges. So I think the challenge is not do we have the communities of learning, it's how do we perhaps organize them even more around specific problems.
So would each of you like to take maybe 1 more minute for some closing comments? Brooke?
Sure. Okay, so our things that used to keep me up at night that don't anymore. I'm just an example of a successful change since Karen's reminding us. Timeouts. So Mike Rice, thank you very much. Raise your hand, say hello. That's Dr. Mike Rice, he's your medical director for patient safety. And Nicole, as the patient safety officer, have been doing some really hard work to get us to standardize our use of timeouts throughout the system. And you go, really? Doesn't that, I bet everybody, raise your hand, you know what a timeout is, right? And you would think that's something we do, right. So we don't. Yeah, it's like hand hygiene. But there was change and we got to change and we got to a place where I think I can rest easy that we are making sure that we, for example, are in clinic and we have just the patient there. We're going to make sure the patient and we are on the same page about what's happening to them. Seems simple, but that's progress. So how did we get there? Well, it was alignment of priorities from a system perspective because we had too many procedures where it was the wrong procedure with the wrong patient at the wrong time, right? It came from data, but the data wasn't the change. We had the clinical leaders and the support from the team to do the local partnership to get the work done. To me, that's what we want. So we got to keep going. I say if we can't play everywhere, that's why we call back the priorities, right? If we play everywhere, we won't win. So let's focus on those priorities. We've been successful. We can be successful when we do team-based care with the patient at the center. And then I think we feel better too, Ranjit. I think there's less burnout when we see it. So I'm energized. I know there's a lot of brains in this room. I know there's a lot of brains in the system. Let's be the change we want to be.
Nicole?
Thanks. So I guess only my comment is that we brought high reliability to our institution after we tried to analyze safety events by the each. And we saw that there was just a bigger trend of that culture and that system design. And high reliability is about performing consistently as intended over time, right? You have your fewer than your fair share of accidents. But it's not just about telling people to try harder, although we really are doing a lot of behavior influence. Like when you talk to your cable company, you're very careful about spelling out your last name with phonetic clarification or right numeric, like I want you to know I'm Templeton with a T, not a P, as in Peter. So I do think that there's some very fundamental ways that we can reduce error that humans can contribute to. And I think that there's ways we have to figure out how to design our system. And patient safety is I used to do quality, doing the things you should do that are found in evidence to be best practice. Patient safety is making sure that things don't go wrong. How do you know what is about to be the next thing that goes wrong, right? It relies on people. It relies on relationships. It relies on teams to recognize it. So this work isn't just going to come out in a single paper, but it is going to rely on all those single papers to become the movement. And I just really appreciate the chance. People have said, why don't you publish that, Nicole? And I say, I'm moving too fast. I don't have time. So if anybody wants to sit with me and I can tell you how we got hand hygiene above 90% consistently and you want to publish it, I'm happy to. But that's the reality of our work in operations, right? We're moving so fast. We just feel like we don't have time to learn from what we just did, that was that great thing. So I'm always appreciative of people who sit and take that time to teach the world what they learned. So just thank you.
Andy?
4 things I'd like you to take away. The first is you chose to be here today compared to other choices you had. That defines you as someone who's part of the learning health sciences community, one way or another. Some are world experts. Some have been working on this like Matt ever since I met Matt 10, 11 years ago. Others of you are new to this, but you're defining yourself within that community. Don't underestimate the evangelical side and the coordinating and community side of your roles in this framework, if you will. The second, related to the first, is define where in the framework your particular interests and expertise lie. You understand the whole, but you also have areas of work that are more focused. I actually chose data in it. I could have chose other areas around the implementations or even the academic side. I chose one that I happen to think is particularly relevant to our work, also some of my background. The third is I've been spending time now, part of that evangelizing and educating side, to teach to the best I can some of our leaders in Michigan medicine this concept of digital. And I'm being very explicit about this. Digital is not IT. Digital is how work is done in a variety of areas that is supported by, enabled by, modified by technology, but it is not IT. It's work. It's education, it's investigation, it's clinical care, it's operations. But digital is changing the way we work with that technology. You definitely can see it now with the growth and the hype around AI. Think about when you will allow an agentic AI to do something in an automated fashion that you right now require not just a person, but a person with expertise to do. Think about all of what's going to be needed for you to allow that to work, let alone for it to work well. And then the fourth is this idea of financing. To the best that you can, try to align that work around the people, those experts that I mentioned, who I believe have formal roles in digital, our CMIOs, our technology leads, many of our operational leads who, I don't understand IT. That's not the right thing to say anymore. Because in many ways, the type of server that we buy or the type of CPU that we're going to use or the manufacturer of the GPU for AI is not important. It's what you're going to do with the output of those technologies. Align your work to the strategies and tactics within Michigan Medicine that you know about, where there is interest, effort, priority, and funding in order to get your work done and meet those needs and goals of the others in our organization. Focusing in those areas, I think, will help define what a learning health system is, because in many ways we have the elements, and it'll help advance it in your area of interest and then collectively as a community.
I can't thank you enough. This has been fantastic. Thank you so much. I mean, this really went beyond expectations. I have to listen to it again to make sure I really got the points. Okay, well, folks, just before we go, just a couple of things. First, QR code to claim CME credit. Leave that up there for a second if anybody wants to point their phone at it. And I'm sure the QR code will be on the website as well. All right, so just we have some great programs coming up. January 7th, mark your calendar. Robert Reed is coming from Toronto, and he'll be speaking to us about the tremendous success he's had as a learning health system there. I'm really looking forward to that. And then on February 12th, a virtual program with the Cerebral Palsy Research Network is going to tell us about how they developed a national program of a learning health system related to cerebral palsy. And that's it. Thank you, everybody.